Before surgery, the important question is not only whether to stop Ozempic or Mounjaro, it is what your doctor needs to hear before anesthesia starts. These drugs can leave food in the stomach longer than expected. That can change fasting, medication timing, and the risk of stomach contents reaching the lungs during sedation. That is why one missing detail can change the whole plan. Many patients say only one thing: I take a weight loss shot. That does not give the team enough to work with. Your surgeon and anesthesia team need more than a label before they can judge the risk. That matters because the issue is not the pen by itself. The issue is how your body is handling food and fluid right now. A person can look calm, feel mostly fine, and still have a stomach that is emptying slowly. That is why surgeons and anesthesia teams ask for these details early. I'm Dr. Kim, a licensed physician. This is not medical advice. Consult your doctor. Ozempic, semaglutide, and Mounjaro, tirzepatide, help with weight loss, partly by slowing how fast the stomach empties. That can reduce hunger and help blood sugar. It can also leave food sitting in the stomach longer. This is more likely after a dose increase or during nausea, bloating, or constipation. That slower movement matters before surgery because anesthesia weakens the reflexes that help keep food out of the lungs. If food or liquid comes back up, it can enter the lungs. Doctors call that aspiration, which means food or liquid goes into the lungs. You only need to know why food timing, symptoms, and the last dose suddenly matter more. Many people think the whole decision is simple: just stop the shot and the problem is solved. That is the wrong frame. The real risk depends on the procedure, the anesthesia type, your symptoms, your dose stage, and whether diabetes is part of the story. A calendar alone may not protect you. Some patients follow the date rule perfectly and still arrive with fullness, reflux, or vomiting. Others take the medication, eat normally, have no symptoms, and may not carry the same stomach risk at all. The team also needs to know why you take the drug. Diabetes, weight loss, and other parts of your care can change what the team worries about most. The same drug can create different surgical questions in different patients. Why you take it is one part of the picture. Dose stage matters too. A steady dose for months is one situation. A fresh dose increase is another. Restarting after a break can also bring symptoms back hard. Those transition periods often tell the team more than the label does. Tell the team if your last dose happened later than planned. Procedure type matters too. Light sedation for a short procedure is not the same as major surgery under general anesthesia. Elective surgery is not the same as urgent surgery. Some patients still eat normal meals. Others feel full after a few bites and bring food back up at night. Other medicines matter as well. Insulin, some diabetes pills that can push blood sugar too low, pain pills, and some constipation medicines can change your surgical risk. Some raise low blood sugar risk when eating is poor. Others can slow the gut further or make dehydration worse. A clean medication list helps the team see the whole problem instead of only one piece. Your history matters too. Mention any past problem with very slow stomach emptying or severe reflux. Also mention any past bowel blockage, pancreas problems, or gallbladder disease. These do not automatically mean surgery has to be delayed. They do tell the team that stomach symptoms on these drugs may deserve a more careful read. The warning signs you should report are mostly stomach and hydration clues. Tell your doctor about ongoing nausea, vomiting, bad bloating, severe constipation, belly pain, or reflux that suddenly got worse. Tell them if food feels stuck for hours. Tell them if you are eating far less because normal meals have become hard to finish. Tell them about body changes too. Dizziness when standing, darker urine, weakness, trouble drinking, or a dry mouth can point to dehydration. People often underreport that because they think low appetite means the medicine is simply working well. Sometimes it does. Sometimes it means the body is going into surgery dry, underfed, and less prepared. Night symptoms deserve attention too. Tell them if sour liquid comes up when you lie down. Tell them if you wake coughing after meals or feel pressure in the upper belly for hours. Those clues may suggest that food is not clearing as expected before anesthesia is planned. When those symptoms are present, the team may read your risk very differently. That is when specific reporting matters most. If any of those symptoms are happening, call the team and report the facts that change the plan. Give the exact drug and dose, give the date of the last injection. Then describe the symptoms you had in the last 1 to 2 weeks. Tell them whether you are still eating normal solid meals or only getting down small amounts. Mention separately if your injection day recently changed or your weekly schedule became irregular. During that same update, also mention any recent urgent care visit. Also mention any time you needed fluids through a vein or any vomiting episode, even if you felt better later. Once the team has those details, ask direct questions about the plan. Ask whether to hold the medication. Ask whether your diet needs to change before surgery. Ask whether fasting or other medicines need to change too. If diabetes is part of your care, ask how blood sugar will be managed while the drug is held. Clear answers matter more than vague reassurance from a rushed phone call. After you ask about medication and fasting changes, ask one practical question too. Who is giving the final instruction here? Sometimes the surgeon's office assumes anesthesia will decide. Sometimes anesthesia expects the prescribing doctor to guide the plan. When that ownership is unclear, mixed messages are more likely. Do not make silent decisions based on a social media post or a friend's experience. Different surgeries do not all use the same plan. Different anesthesia types do not all carry the same stomach risk. The safer move is to contact the surgeon, anesthesia team, or prescribing doctor early enough that they can agree on one plan. The best prevention is early communication and honest tracking. Bring up the medication when the procedure is scheduled, not the night before. Write down your recent injection dates, your dose changes, and the symptoms you actually had. Bring a photo of the pen label too. This makes the team's decision more accurate and reduces avoidable surprises around the procedure. That is why, before surgery, your doctor needs timing, symptoms, dose changes, and the reason you take it. The memorable rule is simple. The safer plan comes from accurate details given early. Give them before anyone is rushing on procedure day. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.